Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Welcome, everyone. We'll be talking today about improving recognition and severity evaluation of pulmonary hypertension in the setting of interstitial lung disease. I'm Dr. Jean Elwing, and I'm a professor of medicine and the director of the Pulmonary Hypertension program at the University of Cincinnati. I do have some disclosures listed here: advising, research, and speaking. What I want you to take away from this lecture is to be able to detail early signs and symptoms and assessment to facilitate a timely and accurate diagnosis of pulmonary hypertension in the setting of interstitial lung disease, or ILD-PH. Employ updated approaches to assess the severity of pulmonary hypertension in these patients, and to identify the significance of screening for mild borderline pulmonary hypertension, and to facilitate early intervention. We want to talk about the safety and efficacy of approved therapies and emerging treatment strategies for these individuals. So let's start by talking about the burden of this condition. This is clinically defined as resting mean pulmonary artery pressure of greater than 20 by right heart catheterization. What does that translate into? It's a debilitating complication among patients with ILD. It's associated with reduced exercise capacity, greater desaturation, poorer quality of life, and worse prognosis. So all very important things. And when we talk about definitions of pulmonary hypertension, it can be confusing because it seems to be somewhat of a moving target. So I'm going to try to bring you up to speed on this. In the 2018 World Consensus from the World Symposium on Pulmonary Hypertension, the definition was a mean pressure of greater than 20 for all patients with pulmonary hypertension, and we've maintained that criteria. For precapillary disease, it required that mean pressure of greater than 20, not elevated left-sided filling pressures with a wedge pressure of 15 or less. And in the past, in 2018, it required a PVR of 3 or greater. But that was looked at in more detail in large patient groups. And we found that the outcomes are poor even at lower pulmonary vascular resistance levels. And it was changed later to a mean pressure of greater than 20 with a PVR of greater than 2 to meet that criteria of precapillary pulmonary hypertension. And this is important because we're going to hopefully be able to include more patients in the definition of ILD-PH and then hopefully intervene earlier over time. So one thing I'd like to bring your attention to is we're trying to reclassify and regroup this condition to better find patients who need assessment and treatment. In the past, in the World Symposium groups, we had hypoxic pulmonary hypertension, and it was defined as how the lungs were disordered, restrictive lung disease or obstructive lung disease. And now it's really defined by the type of condition that's causing the problems in their lungs. And that classification now includes COPD, ILD, CPFE that combine pulmonary fibrosis and emphysema and other parenchymal lung diseases. And so definition-based. And that helps us be able to group patients by disease management and hopefully helps us identify patients earlier by dividing them out in that pattern. And also tells us that this is not going to be diagnosed by an elevated PA pressure on a heart cath and an abnormal pulmonary function test. We really need to dig deep, use our multimodal approaches, and figure out what process is occurring in the patient's lungs. How often does this happen? Well, more frequently than you likely think. ILDs are varied. There's more than 200 different types. So we don't expect you to know all of the ILDs. None of us can do that on a regular basis that aren't ILD experts. But we do want to be aware of fibrotic parenchymal lung diseases and what may happen as they live their lives. The prevalence based on big data sets looking at number of studies can range anywhere from the teen range to more than 80%. And if you look here at this report from 2022, in IPF, the prevalence of PH reached more than 80% in some of the studies. And in the combined pulmonary fibrosis and emphysema, up to 50%. And that was also seen in the hypersensitivity pneumonitis group. So this is not a rare problem, but we're not identifying it as frequently as we should. And these studies use the old definition of pulmonary hypertension with that mean of 25 or greater. So there are patients that were not even included that would be included now in our current definitions. What does that diagnosis of pulmonary hypertension in the setting of ILD translate to in terms of interaction with healthcare workers and cost? Well, it's significant. And I want you to take a second and look at this graph here. It really drives home the point that before you were diagnosed with pulmonary hypertension in the setting of ILD, the access to care and the cost of your condition was far less than after. With hospitalization increasing from 29.5% to 59% pre and post 12 months diagnosis of ILD-PH. ICU use more than doubled. The cost of your medications increased from about $35,000 to $95,000 in those groups of patients. So an important impact on outcomes for the patient, but also the cost of their care. So what I want to leave you with from this section is the prevalence of ILD-PH has been underestimated, under-recognized by previous studies. And the new definition of a mean pressure of greater than 20 will result in substantially higher number of patients that meet the criteria for this condition. And lowering that threshold of PVR to greater than 2 to define that pre-capillary pulmonary hypertension also will increase prevalence. And given the morbidity, the mortality, and healthcare burden, it's critical that we're aware, we suspect, and we look for this condition and diagnose it appropriately. So how do we do that? It's sometimes easier said than done. So if you think back how you learned about pulmonary hypertension and lung disease, we thought it was the disease in the lung parenchyma was marching along. And subsequently, you developed some pulmonary hypertension because of loss of pulmonary vasculature. However, we've learned over time there is no correlation between the degree of restriction and fibrosis and the hemodynamic impairment. So it is not just a result of damaged lungs. There's a complex interplay between tissue destruction, inflammation, fibrosis, hypoxia that exacerbate each other. They drive each other's processes. And there's this high coincidence. As I mentioned, more than 80% in some IPF studies of patients who develop pulmonary hypertension. And really, we believe that it's likely a shared pathophysiology with those triggers of hypoxia, endothelial dysfunction, oxidative stress, inflammation, immune pathways, and genetic predisposition that take you from fibrosis to pulmonary vasculopathy and fibrosis. And if you look here at this individual who has advanced parenchymal lung disease and you look at a biopsy, you'll see in this biopsy specimen that not only the lungs are altered, but also the vasculature. And it's not just an on-off switch. You don't just develop pulmonary hypertension and that's the end of the story. The destruction goes on as the disease worsens. And initially, you might have mild increased pulmonary pressures, but over time, disease will worsen and ultimately result in right heart dysfunction and right heart failure. So we really want to be able to think about this early and detect it before we've reached that point of significant right heart failure. So how do we do that? We have all these symptoms that are overlapping, and there's this complex interplay. But what I'd like you to look at here is this graph showing you the symptoms of ILD with initially you have fatigue, some cough, some shortness of breath, and those worsen. And then at some point, you change to have more of the pulmonary hypertension type symptoms. How to discern when that's exactly happening is impossible without additional testing. But many times you start to develop more dizziness, and it might be low oxygen, and then you start to have swelling and right heart failure symptoms and end stage disease. So it's important to know that those symptoms can change over time, and they may give you a hint that something is going on in the pulmonary vascular bed. So, what I'd like you to take home from this is that pulmonary hypertension is not just the end product of ILD, but they share a pathophysiology. That pulmonary vasculopathy and ILD-PH should be considered a continuum rather than two separate processes. They're interplaying. There's significant overlap of symptoms, and it poses a challenge in screening and diagnosis. So what do the experts say? In a recent publication that was a Delphi analysis that's just really trying to find consensus on a disease process with a group of experts, the Delphi consensus for ILD-PH came up with some guidelines for us. And they said, in terms of signs and symptoms, they were very worried about pulmonary hypertension as a group when patients had advanced symptoms like syncope, JVD, swelling, ascites, abnormal heart sounds with a loud P2, hepatomegaly, dizziness, and palpitations. And those are things that would really drive us to further evaluate. But those are oftentimes late symptoms. They could not find a consensus on some of the other things that may concern us, like dyspnea on exertion, shortness of breath, cough, arrhythmias, fatigue. Those things they were not able to come together to say, yes, that is a warning sign for pulmonary hypertension. All of those we should pay attention to, address, evaluate, but as a group, really the right heart failure signs and symptoms were the most concerning for the Delphi analysis. What else did they guide us with? Well, they came to consensus on what testing abnormalities we should look at. And it should include all the tools in our toolbox. We can't ignore the PFTs, the CT scan, the oxygenation, as well as the labs. So what I want you to concentrate here is I'm going to break them down into groups, and then the big bells, whistles that should go off when you see these changes. In your pulmonary function testing, you want to look at the ratio of the FVC and the DLCO. You want to know if the DLCO is declining more than the rest of your pulmonary mechanics. So the DLCO decline of greater than or equal to 15%, a DLCO less than 40%, worsening FVC to DLCO, or that percentage greater than 1.6 should prompt concern for pulmonary hypertension based on the Delphi analysis. Looking at the CT scan, it's more than the parenchyma. We need to look at the whole picture, get the most out of the study, look at the size of the RV, the size of the pulmonary artery, and that ratio of the PA to the aorta. And if it's greater than 1, we need to be thinking, what is going on in the pulmonary vascular bed? If there's need for more supplemental oxygen, more desaturation, or lower walk distance, think, is something new going on? What could be happening? And it could be changes in the vasculopathy. And we'll also take into account the labs. If available, we want to look at the NT-proBNP and the BNP. Is that BNP greater than 200 or that NT-proBNP greater than 395? If so, that should trigger us to consider ILD-PH. So how do we put this all together? Well, you cannot look at a patient with one or two tests. We have to look at the big picture. We want to see them, assess them, talk to them, examine them, look at the evaluation that's available. And if our patient has anything more than no suspicion for pulmonary hypertension, we want to go on to the next step, get our echo, and then proceed to right heart catheterization in the appropriate patients. So I think you can use this tool to determine when you have any suspicion for pulmonary hypertension and then go on to the next steps. So there are other tools to use, and one I want you to be aware of is the Ford model. And that's where you actually calculate a score. And that's looking at very similar things: the FVC to DLCO ratio, the oxygen saturation low with walk distance, the patient's race, white or non-white, and the distance walked. And each one of those parameters gets a score. And then those scores are added together. And that was able to predict the presence of pulmonary hypertension in the setting of IPF. And if the score was 33 or greater, it was associated with the presence of IPF-related pulmonary hypertension. So another approach, and this one is one that can be calculated and followed. But how good are we? Can we use our own gestalt to determine if patients have pulmonary hypertension? Well, the answer, unfortunately, is no. And in a recent study, the FINDER study aimed to evaluate patients with ILD and determine how to best screen them for pulmonary hypertension, looking at FVC to DLCO ratio, DLCO, TAPSE to systolic PA pressure, enlarged pulmonary arteries, and then if we were able to confirm pulmonary hypertension with right heart catheterization. And they found that even in patients we had low suspicion for pulmonary hypertension, about a third of them had confirmed pulmonary hypertension by right heart catheterization. So of course we need to do our due diligence, evaluate patients, assess and look at all of their testing. But even in the setting of low suspicion, we need to consider further evaluation in select patient populations. More to come on this study as it continues, and we will learn more information from the FINDER study over time. So in summary, early screening to identify patients with ILD-PH may benefit patients by prompting earlier treatment in this high-risk population. Clinical evaluations, looking at signs, symptoms, testing, will help us to determine when to go to the next step for further assessment with echocardiograms and right heart catheterizations. If suspicious findings are present, further testing should be considered, and a confirmatory right heart catheterization is necessary when suspicion is present. So now let's talk about a few cases. Cases are always my favorite to drive home these important points. It's a 68-year-old gentleman, 15-pack-year history of smoking, has a positive ANA, clinical worsening for 2 years, worsening on 6-minute walk distance, and requires supplemental oxygen. Initially, he was just short of breath when he was working outside in the yard. He was a construction worker, plumber for 23 years, but no exposures. DVT-PE 4 years ago and was treated with anticoagulation. He has diabetes, but is well controlled. And he was admitted to the hospital recently for fluid overload and had 2+ lower extremity edema. He did undergo some testing as an outpatient, and you were able to see those when you evaluated him. And you see that his pulmonary mechanics are relatively well preserved. His FVC is above 80% as well as his TLC, but his DLCO is at 38% predicted. And when he walks, he requires 6 liters of supplemental oxygen and desaturates to 86%. His pulse goes to 128, and he's a pulse rate recovery of 16. And when you look at his BNP, it's elevated at 220. Many features that are making you suspicious for the presence of pulmonary hypertension. That low DLCO, that desaturation, the low walk distance, high heart rate, and the elevated BNP. So you want to look at his imaging. And this confirms significant emphysema and some mild lower lung zone fibrosis. So clearly parenchymal lung disease. So how do we get to the right diagnosis for him? We have a lot of suspicion he's worsening. We're concerned about that. So we put it all together. And as we talked about earlier, no part is left out of this assessment. It's a multifactorial approach. History, physical exam, PFTs, exercise tolerance, looking at that CT chest, looking at the biomarkers with the BNP, and then adding echocardiography to that, looking for any changes concerning for elevated pulmonary pressures. But you can't end with the echocardiogram. The echocardiogram is very helpful to look at the right heart size and function. But the pulmonary pressures alone cannot drive you in one direction or the other, because more than 40% of the time, they're going to overestimate the pulmonary pressures. And they also will underestimate the pressures more than 10% of the time, and only 40% they're in the accurate range, based on a study published in 2008 by Dr. Stephen Nathan. So helpful, but not the end-all be-all. We cannot diagnose pulmonary hypertension with echo alone. And we have to be very good clinicians to try to sort out which direction to take the next step. We need to look at the severity of lung disease, the severity of impairment, and then put it together to try to determine what is driving the patient's symptoms and potentially the pulmonary hypertension. I just want to leave you with from this section a thorough physical exam, exercise assessment, CT imaging, biomarker, lung function, and right heart catheterization are useful and all play a role in understanding ILD-PH. Right heart catheterization is the only way to diagnose this condition. We know it's invasive, we know it's time consuming, and it does have complications at times. But we need to use it in the patients we can impact positively when we do get that diagnosis, and then can determine when to refer patients for transplant or treat. So going back to our 68-year-old gentleman with CPFE, we go ahead and get our echo and our right heart catheterization. And as I mentioned earlier, we are very concerned about pulmonary hypertension in this gentleman. His echo has a very high right ventricular systolic pressure estimation at 83. So we're concerned, and we go straight to right heart catheterization. The right heart catheterization confirms that high pressure with a mean pressure of 53, but he has a wedge of 22 and he's fluid overloaded. As I mentioned, he had 2+ edema, he was hospitalized, and we're concerned that now he has this mixed picture, but he has a very high PVR at 6.7, so we are going to optimize and reassess. He asks you about the pulmonary hypertension, and you tell him that any degree of pulmonary hypertension is important. We need to sort this out, optimize your fluid status, and then reevaluate. And if you look at outcomes in patients with ILD and pulmonary hypertension, even that mild increase in pulmonary pressures, that above 20 range level, is associated with significant impairment in survival, which separates at about 6 months with a 50% survival in that 15-month range. So this is not a small impact on outcomes. So important that we dig deep and try to reevaluate and determine what is happening with his pulmonary hypertension. And it does get worse over time. In a study of patients with IPF looking at nearly 100 patients, following for a mean of 1.8 years, mean pressures increased from 16.8 to 20.2 with an annual change of 1.8 millimeters of mercury per year. And that increase in pulmonary pressures was associated with worse outcomes. And we tell you that this pulmonary pressure is changing gradually in the group of patients, but you may have a patient who goes very slowly, but you also may encounter a patient who changes quickly. So this is not something we diagnose and then wait to get worse. We want to assess, diagnose, and address the underlying issues. But what about PVR? We talk about pulmonary vascular resistance. It's a window into the severity of the pulmonary vasculopathy. And just like other forms of pulmonary hypertension, in ILD-PH, higher PVR portends a poor prognosis. And interestingly, in publication from 2024 in Thorax by Sato, they showed that patients, even when they had mean PA pressures in that 20 or less range, if they had an elevated PVR, they had a significant impairment in their survival. So something to think about. We might see these changes early, just looking at the PVR when we evaluate patients by right heart catheterization. So our gentleman, he was started on antifibrotic therapy, he was diuresed, and we optimized his oxygen, made things as well as we could, and we reevaluated. His echocardiogram on repeat showed a little bit lower systolic PA pressure of 50, but now his TAPSE is 1.7, he continues to have septal flattening, and his right heart catheterization was improved in terms of his volume status, but he continued to have elevated mean pulmonary pressure of 30, meeting that criteria for pulmonary hypertension in a precapillary pattern with a wedge of 12 and a PVR of 3.95. So very important that this gentleman wasn't followed up 1 year, 2 years later. We needed to reassess quickly, optimize, and reevaluate. So now I want to change gears to a 57-year-old with ILD changes on X-ray, acid reflux, OSA, on CPAP, very common problems in individuals in this age group. No exposures, no family history of ILD, lifelong non-smoker, no autoimmune disease, and he has crackles. Slightly flat affect, but interactive, able to give you a good story and a good history. You get a chest x-ray, and he has those ILD changes, which prompt our concern for a progressive interstitial process. We go on to get pulmonary function tests, and he has moderate impairment with FVC in that 65% range. His TLC is 72%, and his DLCO is significantly impaired at 34% predicted. His BNP is normal. His walk distance on room air did show some mild desaturation to 89%, and his pulse rate recovery was only 14. So this is a little bit different profile from our previous patient, a little bit more parenchymal lung disease, impairment of his pulmonary function tests, and a low DLCO like our other gentleman. And when we look at his CT imaging, we see significant fibrosis, and he underwent a lung biopsy, which confirmed UIP pattern, and he was diagnosed with IPF and started on antifibrotic therapy. He did undergo an echocardiogram. He had that significantly low DLCO and desaturation. And this confirmed pulmonary hypertension with a mean PA of 25 and a PVR at 3.3. So important findings again, precapillary pulmonary hypertension with a wedge of 9 and an elevated PVR. And we had our signs on our initial evaluation that we needed to follow in addition to managing his IPF. So echocardiogram and right heart catheterization can be used to support and confirm ILD-PH. Discerning what is the driver of the pulmonary vasculature change and that PVR and elevated mean PA pressure needs to be considered, and we need to look at the whole picture. We need to look at other risk factors for pulmonary hypertension, any autoimmune disease, or other factors that could be driving one type of pulmonary hypertension versus another. But when we confirm pulmonary hypertension and we think it's related to ILD, then we need to go on to further assessment and management. And any level of pulmonary hypertension in the setting of ILD is important. It portends a poor prognosis and should be identified and discussed with the patient, and then offered therapies if indicated. There are some controversies, though. When to do testing, how many tests to do, and when not to do testing. The confirmation of pulmonary hypertension in ILD is important not only for treatment options, but also prognostication, transplant referral, and the times to think about proceeding to that right heart catheterization should include any time you're considering any of those options. Right heart catheterization would not be indicated if you're unlikely to treat the patient or the patient is acutely ill and fluid overloaded or has a right ventricular assist device or something that would alter your hemodynamics dramatically. So you want to wait, treat, recover prior to doing your right heart cath. So common sense approach to this, you want to optimize and evaluate in the appropriate patients. So let's talk about a little bit different presentation. A 35-year-old who has connective tissue disease. She has an overlap with ILD, with scleroderma, and overlapping with antisynthetase syndrome. So she has an NSIP pattern on her CT chest, muscle biopsy with inflammatory myopathy. She's on steroids and mycophenolate. Symptom-wise, no chest pain, no palpitations or syncope. And she's using 2.5 liters with exertion. And you do her testing. And she has significant impairment of her pulmonary function with FVC and DLCO in that 35-40 range. And her DLCO is low at 32% predicted. She's on 2 liters desaturating to 89%. And her heart rate goes up to 147 when she exerts herself, but she does have good pulse rate recovery at 21. So different presentation, younger person, higher heart rate, lower lung function. And when you look at her parenchymal evaluation by CT imaging, you do see parenchymal abnormalities and enlargement of the pulmonary arteries on those images you see below. So she is an individual who would go on to have an echocardiogram. Her RV and RA were normal, and you're not really sure at this point how to proceed. This is a patient you would talk with and talk about the risks and benefits of right heart catheterization prior to proceeding because you're not really driven in one way or another by echocardiogram. And when you proceed, she was found to have mild pulmonary hypertension. So this is a really nice example of how the echocardiogram does not give you all the answers. And many will be driven by presentation, oxygen assessment, and your other parameters. So she meets criteria for pulmonary hypertension with a mean pressure of 27, her wedge is low at 9, and her PVR is elevated at 3.6. So echocardiogram can be used to provide additional support, but a normal echocardiogram, as in this patient, does not exclude pulmonary hypertension. Right heart catheterization should be used to confirm when you're suspicious. The decision if and when to get the right heart catheterization should be weighed on a case-to-case basis, and that will really depend on how that will drive decision making. So how do we integrate all of this information into treatment? Well, we talked about 3 unique patients, all of them dysmic, all of them limited, some of them more so than others, all of them with low DLCOs, and all confirmed to have pulmonary hypertension. And their disease will be progressing over time, but at some point, it changes from an interstitial lung disease driven process to a vasculopathy driven process. And at the point the pulmonary vasculopathy worsens, that's when you start to see some additional changes, which we noted before: the low oxygen, decreasing exercise tolerance, lower DLCO. And we find changes on echocardiogram many times, and then confirmed by right heart catheterization, that rise in their mean pressure and that elevated PVR. And I would love to tell you that we have 13 different medications for this condition, but we do not. We have had disappointing results in multiple clinical trials, either with selection of patients or endpoints. I can't say for sure, but we did not hit the mark many times before. And really trying to understand the physiology of this condition better so we can target the right populations. It's difficult to study this patient population. They are very sick oftentimes. They have short life expectancies, and many are hesitant to proceed with invasive testing. So what have we looked at in the past? Starting in 2007, looking at IPF and iloprost did not hit the primary endpoints of 6-minute walk distance and did not change functional class, dyspnea, or oxygen saturations. We looked at sildenafil with IPF several times and did not meet our primary endpoint. We've looked at ambrisentan in IPF, and actually that was terminated early because of progression of respiratory hospitalizations. So that is a drug we recommend against using in our ILD patients with pulmonary hypertension. And we have also looked at riociguat, which was terminated early because of adverse events and mortality. Again, an oral therapy that we recommend against in ILD-PH. But more recently, we looked at inhaled treprostinil, looking at walk distance as the primary endpoint, and it did meet that criteria. And it delayed clinical worsening in that patient population, and it was FDA approved to be used in the setting of ILD-PH, and improves exercise capacity in that patient population. So let's talk a little bit more about that. So the INCREASE study, it was used in inhaled treprostinil in patients with PH-ILD, looking at patients who met that criteria with the conventional previous definition of a mean pressure of greater than 25 and that PVR of 3 or higher, in two groups, either placebo or the treated group. And we found those patients who were exposed to inhaled treprostinil had significant benefit in terms of exercise capacity, with improvement in 6-minute walk distance. And in addition to that, they had less clinical worsening, which included hospitalization, decrease in walk distance, lung transplant, and death, and also impacted their NT-proBNP. So a very impactful study which allowed inhaled treprostinil to become FDA approved for ILD-PH. What about dosing? The important thing we've learned from studies and over time clinically is that we need to reach a certain dose to have best effects. And so in the INCREASE study data, they looked at different levels of dosing of inhaled treprostinil by nebulized formulation and found that those patients who reached 9 or greater breaths 4 times a day had the greatest impact on clinical improvement and decreased clinical worsening. So something important to be aware of, that not only starting this medication in our ILD-PH patients, but also up titrating to a dose that has greatest effect is extremely important. What about mortality? Well, mortality is something that we're always looking for. We want to show that we can not only impact how far patients walk, their BNP, or other parameters, but can we actually impact how long they live? And there are some signals in the INCREASE study that we have longer time to death in those patients who were exposed to inhaled treprostinil. And if you look here, mean time to death in weeks was 58.5 in the inhaled treprostinil group versus 43.5 in the placebo group. So something to think about, and we need to look at this further over time, but thought-provoking. Another way to look at the data is the win ratio. How likely are you going to be winning, meaning getting to a certain endpoint when you're exposed to a medication? And those patients who were exposed to inhaled treprostinil had a greater likelihood of achieving clinical improvement as compared to those patients who did not have exposure to inhaled treprostinil. But what if you don't have that available or you don't tolerate it? Well, there is studies that include large groups of patients in registries that have shown a hint that possibly PDE5 may positively impact outcomes. And in this registry data, we see improvement in survival in patients who were PDE5 exposed when they had PH in the setting of ILD. So something important, this is not FDA approved, but will be considered in the future with further study. So how do we put this all together? We have our patients who have pulmonary hypertension that meet criteria with a mean of greater than 20 and that PVR greater than 2. They were not included in the INCREASE study. So those are patients we diagnose, but then we sort out how to best manage. We follow them and watch them and consider treatment in select patient population. But those patients who meet that criteria over time with that mean of 25 or greater and that PVR greater than 3 would go on to be considered for treatment, considered for referral to transplant, and in certain circumstances would also be considered for sildenafil addition in select populations. The things to remember here is that this is a very complex disease to manage. It requires a global approach, and consideration of referral to a PH program is essential for these patients to have all options, including research opportunities, fast tracking to transplant evaluations. So something to consider for your patients. Other thing to consider is avoid things that could make things worse. We know there's contraindicated meds like ambrisentan from previous study and riociguat from an additional study in this patient population. So what should drive us to treatment or not treatment? We really need to take the whole picture. Look at symptoms, hemodynamics, worsening, BNP, the level of fibrosis, and what drugs are available. And then put that together. Have an open discussion with the patient to determine best strategies, interventions, and management. So to put it all together for us, inhaled treprostinil is the only FDA-approved therapy currently for ILD-PH. The INCREASE study led to reduced clinical worsening amongst patients with this condition. We see that the INCREASE trial and its open-label extension has suggested long-term benefit even in survival, but additional study is needed to better understand that. Patients should be evaluated, monitored, side effects need to be addressed, and we need to watch for potential worsening. We need to avoid certain therapies that have been shown to have adverse effects like the ERAs and riociguat, and phosphodiesterase inhibitors could be considered in advanced patients that we care for or those patients that may not tolerate treprostinil or don't have it available to them. So recommendations to take home: when you have suspicion, we need to look further for pulmonary hypertension and use right heart catheterization to confirm this condition. And look for inhaled therapies for our patients, like inhaled treprostinil, which has been FDA approved, and refer for transplant in the appropriate patients. So with that, I'll end, and I thank you for joining me. Please complete the evaluation on Practice Point CME to claim your credit and provide us feedback. We want to thank you today and thank our sponsors, United Therapeutics, for making this educational program possible.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.